The second element with MURANO that was updated here was the outcome after end of treatment. And overall outcome was quite good. So now we've got 2-year follow-up and 68% of patients remain progression-free with 2 years of follow-up. So for the overall population, this is a very viable strategy. But there is differential outcome, and level of MRD at the end of treatment is the strongest predictor. So of the 130 patients who got to the end of treatment, there were 14, or about 11%, who had high levels of MRD, so above 1% at the end of treatment. The outcome for these patients was relatively poor, with disease progression in over 90% of them relatively soon after treatment. So one of the responses that many people had come up to me about was, well, we shouldn't stop treatment in those patients. Should we continue on the venetoclax? What we'd done was then looked back at the preceding MRD levels in the months prior to drug cessation in those patients. And what it revealed was that these levels were already rising in those patients. So at least in this data set, patients who have high level MRD at the 24-month time point, the vast majority of those actually have incipient emerging resistance. So continuing venetoclax alone is not the answer in that subset. The other patients who either have undetectable MRD or low levels of MRD below 1% are doing quite well. There does appear to be a stratification with those with low level MRD, as we might expect, beginning to relapse now at around the 2-year time point. But our expectation, and we'll need to see whether that pans out, is that they will again be sensitive on reintroduction of the drug. So this concept of the measure of benefit of treatment is through the duration of venetoclax sensitivity rather than the time to first progression, provided that we can demonstrate, again, disease control on reintroduction of the venetoclax. We'd shown that in the earlier phase 1b study, and the MURANO protocol has been amended to now rigorously deliver retreatment and identify response. So that's the next challenge in this sphere. If we are going to use time-limited treatment, which is very desirable both for cost and toxicity, and to limit the risk of selection of a resistant mutation, we need to be able to show our patients with confidence that we can restore disease control at retreatment. So that's the next challenge that we need to go through and prove.